Today we'll be discussing about Hashimoto's thyroiditis. So thyroiditis is a very vast topic. I will be covering what is essential for you to learn, diagnose and treat Hashimoto's thyroiditis, and also in an exam point of view how you can present if a short note of Hashimoto's thyroiditis is asked. What is thyroiditis? Thyroiditis, any itis is inflammation of the thyroid. So Hashimoto's thyroiditis is also an inflammation, a chronic inflammation of the thyroid. But because it is caused due to autoimmunity, it is also known as chronic autoimmune thyroiditis. And because it is autoimmunity, immunity means our white blood cells are involved. So the lymphocytes are deposited in the thyroid gland. Hence, it is also known as chronic lymphocytic thyroiditis. Because of the lymphocytic infiltration, histopathologically, Hashimoto's thyroiditis is also known as trauma lymphomatosa. Chronic autoimmune thyroiditis, chronic lymphocytic thyroiditis, trauma lymphomatosa. What are the causes for Hashimoto's thyroiditis? I will give you a tip. When you are thinking about etiology of something, you think like hereditary, that genetic. So is there something related to genetic? Then is there something that is causing the disease due to where the patient is living? That is environmental. Is that something caused due to an infection by a bacterial or viral? That is infectious. Then you have to think about anything inflammatory, anything else in the body that is causing inflammation. So any inflammatory causes. Then any cause due to what the patient is eating, that is nutritional. So for all disease, not only for Hashimoto's thyroiditis, for any disease, if you are asked a cause, you can think about all this and think if there is anything that is causing the disease. So coming to Hashimoto's thyroiditis, genetic causes can cause Hashimoto's thyroiditis. Lot of genes are involved, polymorphisms of the human leukocyte antigen and polymorphisms of the immune regulatory genes like CD40, CTLA4, thyroid-specific genes like thyroid peroxidase genes, thyroid globulin genes, all this can be affected. Also, Hashimoto's thyroiditis can be seen in people with other autoimmune diseases like vitiligo, pernicious anemia. Also, in conditions like Turner syndrome, Down syndrome, the chance of developing Hashimoto's thyroiditis is more. Next one is any nutritional causes. Whenever you are thinking of thyroid, you think of iodine. We use iodized salt. But Hashimoto's thyroiditis is not related to iodine deficiency. It is related to iodine excess. So if you are taking iodine excessively, excessive supplementation of iodine can result in Hashimoto's thyroiditis or autoimmune disorder of the thyroid. This is because iodinated thyroglobulin creates a more autoimmunogenic intrathyroid environment. So a mild iodine deficiency is okay. Severe iodine deficiency can also trigger autoimmunity. Other nutritional deficiencies that can cause autoimmune thyroiditis are any iron deficiency, selenium deficiency, because selenium and iron are required for the functioning of the enzymes. Thyroid peroxidase is an enzyme that contains heme, and also there are a lot of enzymes that require selenium also for the function, selenoproteins. So deficiency of these can cause deficiency of the proper functioning of the enzyme and trigger autoimmunity. Another thing is vitamin D deficiency. Certain studies have shown that vitamin D deficiency can also trigger autoimmunity. Next is environmental factors. So environmental exposure to chemicals, tobacco smoke, heavy metals like lead, mercury, organochlorine pesticides, bisphenol, triclosan, BPA, all this can trigger autoimmunity. Also some infections like Epstein-Barr virus, Yersinia enterocolica bacteria, all this can trigger autoimmunity in genetically susceptible individuals. So environmental factors always trigger the autoimmunity in a genetically susceptible individual. So there is a genetic factor, environmental factor, nutritional factor, and also a certain other lot of hypotheses have been put forward. Some hygiene hypothesis, people who are not exposed to any infections or any antigens in their childhood can develop autoimmunity in future. And also certain studies in gut microbiome has been done. Problems with the gut microbiome triggering autoimmunity. There is also syndrome known as Thyrogastric syndrome. I'll talk about Thyrogastric syndrome in the end. Epidemiologically, you have to remember one point. Hashimoto's thyroiditis is the most common cause of hypothyroidism. In a place where there is iodine is sufficient, where there is no iodine deficiency, Hashimoto's thyroiditis is the most common cause of hypothyroidism. It is more commonly seen in females, but it can also be seen in children as young as 2 years of age. What is the pathophysiology? Pathophysiology is autoimmunity. That is, our own immune cells are reacting against our own tissues. That is autoimmunity. Both the B cells and T cells are involved in development of Hashimoto's thyroiditis. So there is development of antibodies against the thyroid peroxidase enzyme. That is the most common antibody that is seen in Hashimoto's thyroiditis, thyroid peroxidase antibodies. Another one is thyroglobulin antibodies. Around 50% of people will have thyroglobulin antibodies. Another antibody is TSH receptor antibodies. This TSH receptor antibodies can be TSH receptor stimulating or TSH receptor inhibiting or a neutral one. So most commonly seen TSH receptor antibodies in Hashimoto thyroiditis is TSH receptor inhibiting antibodies. So that the TSH cannot bind and thyroid hormone cannot be produced. That is TSH receptor blockade. But certain people can have TSH receptor stimulating antibodies. Such people, they will develop thyroid related eye disease. Usually thyroid related eye disease is seen in hyperthyroidism. But in Hashimoto's with hyperthyroidism with TSH receptor stimulating antibodies, you can see a thyroid eye disease. T cells are also involved. There is the CD8 plus T cells infiltrate the thyroid tissue, and also CD4 plus T cells stimulates the immune response and production of the antibodies. There is upregulation of the Th1 cells. I will discuss the histopathological features now itself because the pathology is mainly related to the histopathology. That is, there is infiltration of the lymphocytes. So in histopathology also you will see that the thyroid is fully infiltrated with the lymphocytes, plasma cells, and there is destruction of the thyroid follicular cells so that thyroid hormone will not be produced effectively. The entire thyroid parenchyma will be infiltrated with lymphocytes, plasma cells, and lymphoid follicles will be produced, and there will be oncocytic metaplasia. That is, the cells are replaced by oncocytes. These cells are known as Hurtel cells. Large follicular derived cells, also known as Ashkenazi cells, also eosinophilic infiltrates. Progressively, there will be atrophy and fibrosis of the glands, and the patient will develop hypothyroidism. Clinicopathologically, the Hashimoto's thyroiditis can be divided into many forms. First one is the classical form that we have already described. Then you have a fibrous variant in which the histopathologically it will be more of fibrosis. This is associated with idiopathic myxedema in the elderly. The next one is IgG4 related. In this, there will be increased IgG4 cells in the bloodstream, and also there is deposition of IgG4 plasma cells in the thyroid. So histopathologically, you will see more IgG4 plasma cells in the thyroid. Juvenile forms, that is seen in children. It occurs less than 11 years of age, and the mean age is 8 years. Usually presents with a painless thyroid swelling. Then you have hashitoxicosis, that is the form that presents with thyrotoxicosis or hyperthyroidism. Then you have another variant known as silent thyroiditis or painless thyroiditis. This can be seen postpartum also. Usually this is self-limiting. In postpartum thyroiditis, it occurs within 1 year of delivery. What is the clinical presentation? The clinical presentation can be the patient presents you with a thyroid swelling. A patient is asymptomatic and patient would have noticed a thyroid swelling, or somebody would have noticed a thyroid swelling on the patient. Usually it will be females. And these kind of patients can be euthyroid. That is, the patient may not have a thyroid hormonal dysfunction. So clinical presentation can be either in a euthyroid state, or the patient can have a subclinical hypothyroidism. So patient is presenting to you with a thyroid swelling, and when you evaluate, the patient may have a high level of TSH, but T3, T4 can be normal. That is subclinical hypothyroidism. Certain patients can present with symptoms of hyperthyroidism. That is, patient is having high levels of thyroid hormones like tremor, palpitation. All this patient can present. So in this kind of patients, what happens is when there is infiltration of the thyroid gland and destruction of the follicles, already stored hormone is released into the bloodstream. So this causes a transient hyperthyroidism. It's a transient. It will not persist for more than few months, and later the patient will go in for hypothyroidism eventually. And then fourthly, the patient can present with goiter and hypothyroidism. When you evaluate, the patient will be having elevated TSH and reduced T3 and T4 in the blood. Overt hypothyroidism, patient will have symptoms of overt hypothyroidism like fatigue, very weight gain, cold intolerance, constipation, hair loss, confusion, brittle nails, joints pain. And also, patient will have alteration in the menstrual cycle. If the patient is in a reproductive age group, if patient is having Hashimoto thyroiditis and anti-TP antibodies and all, the patient can have recurrent miscarriages. So that can also be a presentation. Postpartum thyroiditis usually occurs within 12 months. When during pregnancy, there will be some immunosuppression for the woman. So when there is rebound immunity, now once the delivery is occurred, the patient may have had a Hashimoto's thyroiditis. So when there is rebound immune response, the patient will go in for a full-fledged Hashimoto's thyroiditis. That is what is known as postpartum thyroiditis. Mostly this will be transient, but some cases can progress into hypothyroidism. So the most common problem with Hashimoto's thyroiditis is the patient can progress into complete hypothyroidism. because there will be fibrosis and atrophy of the glands. And also patients can present with thyroid nodules and thyroid swelling, not only diffuse alignment, thyroid nodules can also happen. And also eye involvement, as I explained before, if it is related to some thyroid receptor stimulating antibodies, patient can present with eye involvement. What are the investigations when a patient presents like this? First, you do the thyroid function test, thyroid stimulating hormone, the free T3, free T4, all this you have to evaluate. And then the thyroid antibodies, anti-TP antibodies, thyroid globulin antibodies, TSH receptor antibody, thyroid stimulating hormone receptor antibody. And also you have to do the general panel like iron study, if the patient is having any vitamin D deficiency, all this you have to evaluate. Also you can do a ultrasound of the neck and the thyroid. Coarse and hypoechogenic parenchyma. The parenchyma is hypoechogenic and there can be micronodular pattern. That is what you see in the ultrasound of the thyroid. You can also do an FNAC, confirm the diagnosis histopathologically. FNAC is important because there can be chances of malignancy. So you have to confirm that it is Hashimoto thyroiditis, and also the FNAC Bethesda category you have to evaluate before you start treating the patient. What is the treatment? The treatment is if the patient is having hypothyroidism, thyroid hormone replacement, you can start the patient on levothyroxine sodium. Levothyroxine has to be taken in the morning, empty stomach. It should not be combined with any iron tablets or any proton pump inhibitors because it will inhibit its absorption. The standard dose is 1.4 to 1.8 microgram per kilogram per day. If the patient is less than 60 years of age, the full dose can be given. But if the patient is older than 60 years and is having associated cardiovascular risks and all that, you can start with a lower dose and then slowly titrate it. In pregnancy, increased doses, like increased to around 30% of the dose can be given as per the requirement. Usually, we initiate the treatment if the TSH levels is more than 5. But in euthyroid women, if they are in the reproductive age group and they are having significant menstrual cycle abnormality or they are trying to conceive, you can initiate thyroid supplements if suspected Hashimoto thyroiditis if the TSH levels are above 2.5 itself. Also, you can supplement selenium, and also iron deficiency has to be corrected. Vitamin D deficiency has to be corrected. Dietary modifications can be advised. Avoid goitrogens like soya, isoflavones, the Brassicaceae family like cauliflower, broccoli, all these foods can be avoided. So avoid processed foods, have a lot of vegetables, fruits, nuts and all in their diet. What about treatment of hashimotoxicosis or thyrotoxicosis? Usually it is symptomatic management. You can give beta blockers if required. Most of the cases, 90% of the cases, the patient will go in for a hypothyroidism eventually. So you have to monitor the TSH levels and decide if the patient is going for hypothyroidism, you will have to supplement with the levothyroxine. Also, in euthyroid patients, if you're not initiating a treatment, keep the patient on regular follow-up because the patient can go into hypothyroidism. So then you will have to initiate a treatment with levothyroxine. Short course steroids can be given for IgG4 related Hashimoto thyroiditis, and it has found to be effective. A short percentage of the people will progress to Graves' disease, especially in people with a TSH receptor stimulating antibodies. What are the indications for surgical treatment? Surgery is not the first line treatment for Hashimoto thyroiditis because the gland can shrink and become atrophied and go for hypothyroidism. It is not the first line treatment. If the patient is hypothyroid, you will be supplementing with the thyroid hormone. But you can do surgery in certain cases when there is a large goiter which is causing compression symptoms. And also, if you're suspecting a malignancy, there are nodules and you're suspecting malignancy, you can go for surgery. What are the differential diagnosis? The differential diagnosis can be a plain goiter. If the patient is having hashimotoxicosis, you can diagnose as thyrotoxicosis, Graves' disease. Also, another differential diagnosis, hypopituitarism. Also, drug-induced goiters like lithium-induced goiter if patient is on some lithium treatment. What are the complications? The complication is patient will go in for permanent hypothyroidism. Another complication is patient can develop malignancy. There is no studies that is showing a strict correlation between development of thyroid carcinoma and Hashimoto thyroiditis. But Hashimoto thyroiditis patients have a chance of developing papillary carcinoma thyroid, and also there's a chance of developing primary thyroid lymphoma. So histopathological diagnosis is mandatory before you continue with the treatment for the patient. What is thyrogastric syndrome? Thyrogastric syndrome is chronic autoimmune thyroiditis coexisting with chronic autoimmune gastritis. They say that the patient may have developed a chronic autoimmune gastritis initially. So there is destruction of the parietal cells and achlorhydria related iron deficiency and pernicious anemia, which in turn is stimulating the chronic autoimmune thyroiditis. Another thing is parietal cells and the thyroid cells have same embryological development from the primitive gut. They also have polarized cell. Both of them depend on iodine for their function. Both cells have sodium iodide symporter. So they also have cells with microvilli. So there can be simultaneous destruction of the parietal cell and also the thyroid follicular cells, causing chronic autoimmune gastritis and chronic autoimmune thyroiditis. The problem with this is when you supplement the levothyroxine for patients with chronic autoimmune gastritis, the levothyroxine may not be absorbed properly. So in these patients, you can give some liquid or soft gel capsules can be advised for these patients. Thyrogastric syndrome is associated with a polyglandular autoimmune syndrome type 3B. If it is coming as an MCQ for you, it will be helpful.